Hello and welcome everyone. When a tooth erupts into the oral cavity, its root aren't developed yet, and it usually takes about 3 years for the root to fully develop. And in order to do that, the pulp of this developing tooth needs to remain healthy. But if it gets exposed during this developmental phase, then the pulp is in the danger of being necrosed. Pulpotomy is a procedure that can save this tooth from going into a necrotic phase. Pulpotomy, also known as pulp amputation, in the 10th edition of Glossary of Endodontics is defined as the removal of the coronal portion of a vital pulp as a means of preserving the vitality of the remaining radicular portion. May be performed as emergency procedure for temporary relief of symptoms or therapeutic measure, as in the case of a Cvek's pulpotomy. More on Cvek's pulpotomy later in this video. Pulpotomy is considered a vital pulp therapy procedure in which the coronal pulp is surgically excised, leaving the intact vital radicular pulp. Coronal pulp is the pulp present inside the chamber, while the radicular pulp is the pulp present inside the pulp canals. If the exposure had occurred due to a carious lesion, then all carious dentine and the coronal pulp is removed, leaving behind the radicular pulp. By leaving this radicular pulp behind, the undeveloped tooth may continue its development and may remain vital for indefinite periods of time. Hence, pulpotomy provides a valuable solution to maintain the vitality of the pulp and to help the tooth continue its development even after exposure. A variation of pulpotomy is the Cvek's pulpotomy, otherwise known as partial pulpotomy, in which not the entire coronal pulp is removed, rather only the more superficial 2 to 4 mm of diseased pulp is removed. Cvek's pulpotomy in the 10th edition of Glossary of Endodontics is defined as the removal of a small portion of the vital coronal pulp as a means of preserving the remaining coronal and radicular pulp tissues. This technique of partial pulpotomy has a much higher success rate in keeping the pulp vital later onwards as opposed to conventional pulpotomy. As in Cvek's pulpotomy, more of the vital pulp is left in the tooth. The success rate is even better when pulpotomy is performed in teeth with mechanical exposures that are caused by trauma or something similar, rather than those exposures that are caused by caries. After excision of superficial 2 mm of diseased pulp, as in the Cvek's pulpotomy, or entire coronal pulp, as in conventional pulpotomy, hemorrhage is controlled. Then the remaining pulp is capped with MTA, that is mineral trioxide, or previously used calcium hydroxide, and then a permanent restoration is placed to achieve good seal. I've talked more about this procedure in my apexogenesis video. Now both conventional pulpotomy and Cvek's pulpotomy have a better success rate if done in incompletely formed teeth that are still developing, especially in primary teeth. But they can be considered in permanent fully formed teeth because the primary goal of any endodontic therapy is to maintain the vitality of the pulp. But remember, for performing pulpotomy, whether it is conventional or Cvek's pulpotomy, the pulp must be vital and asymptomatic or have mild symptoms of reversible pulpitis. Only then can the pulp sustain vitality and further growth after performing pulpotomy. Now let's do a simple clinical question to understand the topic even better. A 7-year-old male patient came into your OPD with his parents for a carious lesion on his 3-6. 3-6 in FDI means that it is a permanent lower left molar. The patient's parents are giving a history of pain while chewing something, otherwise there were no signs and symptoms whatsoever. You place a rubber dam and start to remove caries using your handpiece. During caries removal, you notice blood coming from the cavity which was otherwise isolated. You place a cotton in hopes of controlling the bleeding, but the bleeding from the cavity does not stop. What should be your next best possible approach? A. Complete the pulp removal and initiate root canal treatment. B. Apexification. C. Cvek's pulpotomy. Or D. Direct pulp capping. So you have 5 seconds to read the question once again and then I will try to explain you the answer. So there are two very important things to consider here. First, the age of the patient, that is 7 years, and the second thing is the tooth, that is 3-6. We all know that normal age of eruption of the first molar is around 6 to 7 years and it takes around 2 to 3 additional years for the root to fully develop. So without root completion and apical closure, root canal treatment is not possible. Not to mention the tooth also lacks signs and symptoms of irreversible pulpitis. So going for root canal treatment is illogical. Same goes for apexification. Even though apexification is attempted on teeth with immature apices, apexification is usually recommended if the tooth had signs and symptoms of irreversible pulpitis or the pulp is already necrotic and also has an immature apex. So in these teeth, apexification is attempted so that the root enclosure can be achieved. Hence, in this case, when the tooth is reported healthy prior to exposure, apexification is also the least likely answer. Now, of course, X-ray plays a huge role in helping to confirm our diagnosis and formulate a proper treatment plan. And clinically, it is and should be a huge staple for a dentist in reducing diagnosis. And in such developing teeth, X-ray should be done to visualize the developing root. So moving on, now there is some dispute when it comes to choosing between direct pulp capping and Cvek's pulpotomy, as both approaches are valid when it comes to protecting the pulp with no prior symptoms or tooth with mild symptoms. But there is also one more key detail in the history which would suggest the definitive answer. Can you pick that up? It is the detail of hemorrhage control or the bleeding control. As it is stated in the question, the hemorrhage or the bleeding did not stop after trying to stop the bleeding, which is suggesting that there may be some irritated pulp still present. With hemorrhage control not being achieved, the next best thing to go for us among the options provided is the Cvek's pulpotomy. So Cvek's pulpotomy is the best possible answer among all. And clinically, if hemorrhage is not controlled even after removal of 2 to 4 millimeters of the pulp, then the next best thing would be to go for the conventional pulpotomy. Now what if this detail is not given to us? Then how do we decide that whether it is Cvek's pulpotomy or direct pulp capping? Now there are many articles and researches that compare the cases treated with direct pulp capping and Cvek's pulpotomy. And both treatment plans, when done correctly, have a high success rate. But when it comes to a clinical question such as this one in an exam, you need to pay attention to the details provided. Whether the tooth had signs and symptoms before the exposure, which type of tooth it is, and finally the most important part is the cause of exposure. Many literature suggests that it is best to go for Cvek's pulpotomy in an exposure caused during caries removal, and to go for direct pulp capping in an exposure caused by mechanical trauma, especially if the tooth is primary, because Cvek's pulpotomy allows for the removal of much of the infected dentinal debris caused after a mechanical exposure of a deep carious lesion, hence reducing the infectious challenge such debris presents. While a tooth with only traumatic exposure with no prior lesion is a much better candidate for a direct pulp capping. But the decision between Cvek's pulpotomy and direct pulp capping is really the dentist's call and his or her clinical judgment, and varies greatly from case to case. And both the procedures have good success rate as evident by many researches. So this was all in this lecture. I hope this video was helpful for you. As always, take care of yourselves and your loved ones. Stay safe and goodbye.